Thanks for giving us the opportunity to present our data. I would like to start with pointing out a few of the challenges that we are facing in the treatment of prostate cancer. It was summarized very nicely by Dr. Sartor in his opening remarks and then expanded this morning by other presenters. We have multiple treatment options for our patients with advanced prostate cancer, but one of the challenges that we are facing is the appropriate treatment sequence and or combination of these agents to improve the efficacy and prolong the duration of response with an acceptable side effect profile. Radium-223 plus best standard of care in our SIMCA trial showed improved overall survival and delayed the symptomatic skeletal events in men with chemo-naive or chemo-refractory symptomatic metastatic CRPC. But at that time, the newer hormonal agents such as abiraterone and enzalutamide were not available. So the best standard of care was defined as local radiation therapy, glucocorticoids, antiandrogens, ketoconazole, or estrogens. And limited data exists for the sequencing or concomitant use of these newer agents with radium-223. So we conducted a retrospective study for patients with metastatic CRPC and predominant bone disease who received radium at the Cleveland Clinic and Tulane University prior to any systemic chemotherapy. And prior therapies for CRPC were collected, including the best standard of care as defined by the investigators in each one of these institutes. Special interest was paid to those patients who received concomitant ABI and ENZA with their radium treatment. Grade 3 and 4 adverse events were recorded using CTCAE, and efficacy was defined using PCWG2 criteria. And changes in PSA and alkaline phosphatase values were recorded. 51 chemo-naive metastatic CRPC patients with predominantly bone mets were identified. They received radium in between February of 2012 and August of 2014, 27 patients at Cleveland Clinic and 24 patients at Tulane. Median age at diagnosis of 63, with 33% of the patients 70 years old or older at diagnosis, and 72% of these patients had gleason 8 or higher at diagnosis. 67% received prior abiraterone and 16% received prior enzalutamide prior to the radium treatment. And then concomitant with the radium, 24% received ABI and 20% enzalutamide. 47% of these patients had visceral mets in addition to their bone mets, and the median hemoglobin ANC and platelet prior to radium treatment is listed in this table. At the time of this analysis, the median number of radium cycles received was 5, ranging from 1 to 6, and 39% of the patients received all 6 cycles of treatment. 35% of them stopped treatment due to progression of the disease, 8% due to toxicity, and 14% of them were still on treatment. PSA decline more than 30% were observed in 31% of the patients. All but one patient had at least some decline in their alkaline phosphatase, and more than 30% decline in alkaline phosphatase was observed in 68% of the patients. Grade 3 and 4 adverse events was observed in just 4 patients, grade 3 anemia in 3, and grade 4 thrombocytopenia in 1 patient. And there was no difference in adverse events with concurrent ABI and ENZA use. And although it was a small study with a small number of patients, but concurrent abiraterone treatment was associated with longer overall survival. In conclusion, treatment with radium in combination with either ABI or ENZA is safe and feasible. Hematologic adverse events of radium treatment in this study was the same as reported in our SIMCA trial. ABI and ENZA could be considered standard of care and offered to metastatic CRPC patients receiving radium-223. Later on, similar safety and tolerability results were demonstrated in the American and international expanded access settings, and multiple phase 3 randomized trials are ongoing to further investigate the combination of radium-223 with these agents and many other agents. And I would like to thank Dr. Sartor, our collaborator, and his team at Tulane, and our GU department at Cleveland Clinic, and our patients at Cleveland Clinic and Tulane University.
Thank you very much. I don't know if I should ask questions or not.
I had a question. It seemed like in that, and tell me if it may, but you had about 47% that actually had some non-bony lesions, which seems a little higher than what the asymptote is. That the trend that you may that people, because of getting the hormonal therapies, are treating some patients who wouldn't have, quote, maybe been as eligible for the Alsimta, or did they still fit the criteria for the Alsimta trial?
I think these patients were, most of them, at least as far as I know, were not in the Alsimta trial. And you're right, these patients had more visceral mets compared to that. Some of them might have not been eligible for Alsimta because of the restrictions for the visceral mets. But one thing, these are a little later on treated too. So it's kind of like the after approval, but not the expanded access. But so what gets to the point is that the reason that we used Abi or Enza in these patients, some of them were on Abi or Enza prior to getting to the point that they needed radium, or we decided to start them on radium, and we continued those because of their visceral disease. So I think that 6 months, if we, the idea behind it is if we are going to stop the systemic treatment to go for the radium treatment for 6 months, you're losing the battle for the visceral mets that they have, and that might progress.
Thank you.
Yeah, and I think, this gets a little bit back to the data I showed earlier. Radium, at least in a selected patient population, seems to help with control of the disease in bone, but the vast majority of progressors are coming outside of the bone. So, it's hard to give a bone-targeted agent to somebody with the multiplicity of soft tissue mets, and we just have to use our best standard of care to try to make that better. But when we're putting together this database, we really didn't have much about the safety or potential efficacy. Obviously very, very small data set when looked at in a big context of things, but still had some potentially interesting results. All right.
I have a question behind you.
Oh, I'm sorry.
Me again. Nice presentation. Quick question that I've had just from the experience I've had giving radium is, what do we know outside of the context of Alsimta or clinical trials, or what do you think about the use of chemotherapy post-radium, and are we able to, are we getting a benefit upfront with the radium that we're taking away from a benefit we could apply later with chemotherapy? I'm not saying one is better than the other, but is it a trade-off, or is it a sequential thing? What do you, because my experience is that it's hard to give docetaxel, cabazitaxel after I've given a full course of radium.
I'll take the best shot at answering it, and I think the best honest answer is that I don't know. What we did and presented this at Emamekhoo this year was a 3-year update on our prior data, and the deficiency of it is several-fold. Number one is we really didn't have the doses, so we're not able to talk about the dose of chemotherapy. We talked about the duration, and it really calls, if not for a prospective study, at least a prospective registry.
Unless you had selected in a group of patients who were refusing chemotherapy or were intolerant or ineligible for it.
It was quite interesting, though, when we gave we did our analysis, which I'd be happy to give you the poster. Some of the patients actually who had chemo after radium had actually had chemo before radium too. So it was a mixture of patients, some with prior chemo, some with no prior chemo, then to radium, then back. One of the things that was completely clear, however, that it was a subset of patients that was very atypical. I would love to be able to remember their median survival, but it was like 24 months when the median in Alsimta, even the radium-treated patients, was 14 thereabouts. So, it's a lot of selection, and I think what you may be noticing, I'm not 100% sure of, but I think we ought to have real data, and I think your concerns are valid.
Thank you.
Great, thank you.